radiation. She is on letrozole for long-term suppression. She had developed some bone pain, so last summer her cancer treatment team sent her for a bone density scan, which showed osteopenia at the time. They had referred her to endocrinology for possible treatment, but she really wasn't ready to treat anything. This is somebody who is very, very anxious about her healthcare need, or her health in general, and well, very anxious about the world, I guess. Um, but she had read up on side effects, and when they suggested alendronate, she said no, and I think quit listening. Um, so anyway, she stopped having periods naturally at age 45. Um, Interestingly enough, her mother is also my patient, and this is a very active, kind of live in the woods, put wood in the stove, plant the garden kind of woman who has very severe osteoporosis with multiple spinal fractures. So that's kind of hanging in the back of my mind as I make decisions for the daughter. Um, Her comorbidities, really, the anxiety is the main thing. And then the breast cancer, I've put in some details there. It's HER2 negative. It was a multifocal tumor with a one metastasis to an axillary node at the time of her diagnosis in 2021. So this DEXA that they got a year ago showed the T scores that are there on the screen. I mean, the lumbar spine was minus 2.3, which is obviously the one kind of getting our attention. Um, she did have a nuclear medicine bone scan this month, which had no evidence of bony mets or didn't show anything suspicious for a healing fracture or anything. Um, she's had a CT of her abdomen and pelvis, showing no metastatic disease. She's very, very concerned about possible diabetes because her blood sugar has been as high as 103 a time or two. Her A1C was 5.1. She's got normal kidney function. Her vitamin D level has been normal. Her medications are the letrozole, which she acknowledges she's not taking every day. She's previously, I think, had been taking it about 50% of the time, and her oncologist did persuade her to take it 80% of the time. She takes lorazepam for the anxiety. She is not going to quit taking aspirin. She takes turmeric, vitamin C, vitamin D3. We recommended calcium at the time of her visit last week, but I had to do a lot of explaining the fact that, coronary artery disease has to do with calcification of coronary arteries, and that was not going to be accelerated if she took oral calcium. So, my question, aside from all the anxiety things and all that, is what do you recommend for a woman in this situation with the breast cancer, with the bad family history of osteoporosis? What is going to be the best for her in terms of treatment of osteoporosis? And then it's my problem whether I can talk her into it. But yeah, that's my big question, is just what do I recommend?
Thank you so much, Dr. Rexroad, and a really great case to bring to the session. Before we jump into the recommendations and feedback from the Hub members, does anyone have any clarifying questions about this case? And everyone's welcome to unmute or chat in. All right, and any recommendations about this case?
Yeah, I see Dr. Giordano. So, um, so it sounds like she has osteopenia, and her T scores have never been less than 2.5. Is that right?
That is correct.
And it's her mother that had the compression fractures, not her.
Correct.
Okay. Has she ever fractured anything, like her hip or anything like that?
Not to my knowledge.
Okay.
Let's go through her chart here again, but I don't believe so.
Okay. So with osteopenia, that is when we would calculate that FRAX score. And you can just look it up online, FRAX calculator. And so I assume she probably does meet criteria. So with the FRAX score, you want you will treat as osteoporosis if the hip fracture risk is 3% or worse, or if the major osteoporosis risk is 20% or worse. So when you do the calculator online, if she has a 20% major or 3% hip or higher, then you would treat.
Okay.
So with osteoporosis, there's kind of two ways to treat. So you either have the anti-resorptive medicines, which are the bisphosphonates or Prolia, or you have the anabolics, which are the PTH analogs like Forteo, Tymlos, or Evenity, which is romosozumab. So she is not a candidate for Forteo or Tymlos because she has the history of radiation to her breast. Mm-hmm. And that's a contraindication with one of those medicines due to questionable osteosarcoma in rats when they were doing the studies on that. So she can't get one of those. She has not had any fractures, so I wouldn't jump to Evenity at this time. So I do agree that probably a bisphosphonate is her best option. And the reason that I wouldn't go to Prolia immediately is because she's only in her 50s. So with Prolia, you pretty much have to continue it lifelong, like every 6 months, forever, because if you stop the medicine, then there's data to show that their bones rapidly demineralize unless you give like a reclast after you stop it at least once. So that's why I wouldn't start Prolia, especially if she is hesitant to ever get reclassed after, if you needed to stop it. If she were like in her 70s or 80s, I would have no problem starting denosumab in this patient. So I would recommend either a once a year reclast or zoledronic acid or a bisphosphonate like the Fosamax. So whenever patients read about the side effects for these kind of medicines, so with the Fosamax and stuff, the most common side effect is actually just GERD, like bad acid reflux or something like that. And then you read about, like, you tell them about the osteonecrosis of the jaw and the atypical femur fracture risk. But I always counsel patients that when they were doing studies, the risk of getting either of those was about as low as getting struck by lightning. Like, that is how low, when there's even a chart where they compared it to a bunch of different things. And so the morbidity and mortality associated with a hip or a compression fracture is so much higher than the tiny, tiny risk of developing osteonecrosis of the jaw or an atypical femur fracture. And so that's kind of how I'm sometimes able to convince some people. If they absolutely cannot be convinced, then I just keep counseling them about the risk associated with hip fractures and spine fractures and just keep an eye on their vitamin D and calcium over time. I try to get their vitamin D to like the 40s or 50s to make sure it's really enough. Okay. Any questions?
Well, I mean, it's the jaw thing that she is fixated on.
So with the osteonecrosis of the jaw, I think when they were doing the studies, it was like 0.1 case per 100,000 people, and getting struck by lightning, or it was like 0.6 for every whatever 100,000, and then the getting struck by lightning was like 0.7 or vice versa. Like it is so uncommon. And so we do tell them, just follow with your dentist regularly. If you get like any sort of jaw or tooth problems, you need to let me know. And then Fosamax, so it does stay in the system, bone medicine stay in the system longer than other medicines, but because she's so scared, I wouldn't jump to reclast because it would stay in her system months and months. So that's why I would be hesitant. So if you could convince her to do the Fosamax, that might be the easiest thing to convince her if you're able to. But it's not you. It is very hard to convince people to start bone medicines. I don't know why it's just people fear those things more than any other medicine for some reason.
Okay. Well, you've given me some things that I can use to help explain to her. I think one issue was she felt like nobody had explained some of this really well. So I think I can have a good talk with her at least.
Okay. Any other questions about it?
I don't think so.
Thank you.
Yeah, thanks for the feedback. Like I say, I figured out I was going to learn something here, whether
Yeah, thank you so much, Dr. Barghouti. You always learn something new at Echo. That's what I love about it. Any other feedback or recommendations from anyone? And everyone's welcome to chime in. Alrighty, and Dr. Rexroad, you're good with this case then? And as always, if you have further questions after, you can email me.
Absolutely. I think I'm good. I think, like I say, I'm kind of looking for, you know, what is going to be the best thing. And then you've given me some great things to take back and talk with the patient about. So that's what I'm looking for.
Excellent. Thank you so much for bringing the case today, Dr. Rexroad. We appreciate you. Alrighty. Dr. Mawish Martin, are you ready for your presentation? I can make you co-host, so you're welcome to screen share and advance slides, but I have it on my end as well if technology is not our friend today.
Okay, no, that's fine. You can pull it up.
All right. Let me know if there are any issues pulling it up. I'm happy to do it as well.
Do you have the slides?
Yes. Is it giving you the ability to do that, or is it?
Do you want me to share my screen?
If that's what you prefer, you're more than welcome to, but I'm always happy to do that as well.
Okay, let me see. Why don't you go ahead and pull up?
Absolutely. That's what I'm here for. I always tell people that. Are
Thank
you able
you.
to see that okay?
Yes, I can. Can I change the slides from my end or?
I don't think so with the co-host ability. I think it's just only if you screen share on your end, but you can tell me next slide. I'm happy to go back and forth as well. So don't feel bad to tell me which slide you want.
Okay. So hello everyone, this is Mavish. I am from the Department of Preventive Medicine, and today I'll be talking about obesity. Next slide. So first of all, what is obesity? According to CDC, obesity is a common, serious, and costly chronic disease of adults and children that continues to increase in the United States. It is putting a strain on American families, affecting overall health, healthcare costs, and productivity. So next slide. So how do we calculate or measure obesity? We do it by using BMI, which is body mass index. It is a person's weight in kilograms divided by the square of height in meters. A high BMI can indicate high body fat. If your BMI is less than 18.5, it falls within the underweight range. If your BMI is 18.5 to less than 25, it falls within the healthy weight range. And if your BMI is 25 to less than 30, it falls within the overweight range. If your BMI is 30 or higher, it falls within the obesity range. Next slide. So obesity is frequently classified into three classes, class 1, 2, and 3. Class 1 is BMI of 30 to less than 35, class 2 is BMI of 35 to less than 40, and class 3 is BMI of 40 or higher. Class 3 obesity is also sometimes referred to as severe obesity. Next. Now, what are some causes of obesity? There are many factors that can contribute to excess weight gain, including eating patterns, physical activity levels, sleep habits, and stress. Social determinants of health, genetics, and taking certain medications also play a role. Next. Now, there are many consequences of obesity, which are the following, and I will go over them. It causes all causes of death, high blood pressure, high LDL cholesterol, low HDL cholesterol, or high levels of triglycerides, type 2 diabetes, coronary heart disease, stroke, gallbladder disease, osteoarthritis, sleep apnea and breathing problems, many types of cancers, low quality of life, body pains, and difficulty with physical functioning. Next. Now, there are many cancers that are associated with obesity. I took this slide from National Cancer Institute, and you can see that the cancers were going all the way from head to toe. Can cause meningioma, thyroid, adenocarcinoma of the esophagus, breast, multiple myeloma, liver, kidney, gallbladder, upper stomach, pancreas, endometrium, ovary, colorectal cancers. Next. Childhood obesity consequences. So there are many problems that can be associated with childhood obesity. Psychological problems such as anxiety and depression, low self-esteem, and lower self-reported quality of life. Social problems such as bullying and stigma. Obesity as adults can lead to the same consequences as discussed in the previous slides. Next. Now, there is an economic impact as well. Annual obesity-related medical care costs in the United States in 2019 were estimated to be nearly $173 billion. Annual nationwide productivity costs of obesity-related abstainism ranged between $3.38 billion, which is $79 per individual with obesity, and $6.38 billion, which would be $132 per individual with obesity. Direct medical costs may include preventive, diagnostic, and treatment services. Indirect costs relate to sickness and death and include lost productivity. Productivity measures include employees being absent from work for obesity-related health reasons, decreased productivity while at work, and premature death and disability. Next. Now we can see that adult obesity is on the rise. The 2021 CDC adult obesity prevalence maps show that obesity remains high. 19 states and 2 territories currently have an obesity prevalence at or above 35%, more than doubling from 2018. The 2021 states and territories are Alabama, Arkansas, Indiana, Iowa, Kansas, Kentucky, Louisiana, Mississippi, Missouri, Nebraska, North Carolina, North Dakota, Ohio, Oklahoma, South Carolina, South Dakota, Tennessee, Texas, West Virginia, Puerto Rico, and U.S. Virgin Islands. Next. So this slide shows a map of overall obesity in the United States. This is taken from Briefus. It tells you about prevalence of self-reported obesity among U.S. adults by state and territory. And you can see see that there are orange states and then the red ones. West Virginia is there, West Virginia and Kentucky, and the rates are 40% to 45%. And if I talk a little bit about Briefus, it is basically behavioral risk factor surveillance system. It is the largest health survey system in the world that completes more than 400,000 adult interviews each year. The survey is administered by CDC's Division of Population Health in the National Center for Chronic Disease Prevention and Health Promotion. Next. So West Virginia has the highest obesity rate in the country. This was a link that I pulled up from one of the websites. I'm not sure if we can play it. But the next one is taken from one of the articles from Bluefield, West Virginia. And it says the pandemic hasn't helped West Virginians get into shape as the state ranks #1 in the United States when it comes to obesity. It's not the first time that the Mountain State topped that list. Health experts say that this has been the case for a long time. Many factors have led to this, but the main reason is that it is a tough cycle to break because it requires a complete change in lifestyle. It's really hard in rural America to maintain a healthy lifestyle because healthy food is expensive, but it's a lifestyle change that starts at a very young age, says Dr. Amjad, who is West Virginia State Health Officer. Next. So obesity worsens outcomes from COVID-19. Adults with excess weight were at greater risk during the COVID-19 pandemic. Obesity increases the risk of severity due to COVID-19 illness. It may triple the risk of hospitalizations due to COVID-19 infection. Obesity is linked to impaired immune function. Obesity decreases lung capacity and reserve and can make ventilation more difficult. A study of COVID-19 cases suggests that risks of hospitalization, intensive care unit admission, invasive mechanical ventilation, and death are higher with increasing BMI. Next. So I was a part of one of these pilot studies during the big initial phase of the pandemic, and me and my group, we did this study. It was basically about obesity and its relationship with worse outcomes. It was obesity a predictor of outcomes of COVID-19 in hospitalized patients, a systematic review and meta-analysis. And this became a part of public health emergency COVID-19 initiative. Next. So I went on air and talked about what we found out in this meta-analysis, and I gave interviews on various channels and media platforms about this association. Next. So what can we do now? There are three things: lifestyle modification, medical weight management, and bariatric surgery. Next. So what is lifestyle medicine? It's a type of medicine that focuses on your lifestyle and making healthy changes to maintain a healthy BMI. It focuses on 6 pillars, which are whole food, plant-based nutrition, physical activity, restorative sleep, stress management, avoidance of risky substances such as tobacco, alcohol, and illicit drugs, and social connectedness. Next. So next is medical weight management or obesity medicine. It has 4 pillars, which are nutrition, physical activity, behavior, and medication. So in this, you basically get prescription treatment to promote weight loss, which is tailored to meet individual patients' needs. Patients work with a physician, a dietitian, and a psychologist to treat the neurobehavioral component of the disease. It kind of gives you a holistic approach. And then the final step would be, before this, would be bariatric surgery. So this is the final step. It's like the final tool that we can use. There are various surgeries like gastric bypass and sleeve gastrectomy, which can be used as options for weight loss surgeries. But of course, any surgery has its pros and cons. There are post-op complications, and there can be long-term consequences and implications as well. And one of them is dumping syndrome, which you see quite a lot in post-op patients. It is a group of symptoms such as nausea, diarrhea, and lightheadedness that occurs after a meal caused by the rapid emptying of food from the stomach to the duodenum. And it's something not very pleasant in patients who have this or just go through a very hard time. Next. Now, how can we prevent it? Since I am a preventive medicine resident, I cannot complete this without talking about prevention. So reduce intake of highly processed foods rich in sugar or calories and avoid sugary sweetened beverages. Eat whole foods which are dense in nutrients such as fruits, vegetables, beans, legumes, nuts, and seeds, and healthy plant-based fats. Spend at least 30 minutes a day in moderate physical activities such as brisk walking or lawn mowing or, uh, windows, like if you're vacuuming, etc. Learn proportions of meals and snacks. Incorporate physical activity in your everyday life, such as taking the stairs whenever possible and parking your car farther out in the parking lot, etc. Get your household members involved to make these changes sustainable. Next. So it's not too late. Must always prioritize yourself. Take care of yourself first so you can take care of others. Next. Questions?
Thank you so much, Moish. It was a really great presentation. And I love, like you said, it's so relevant because you're in the general preventive medicine residency. So the prevention discussion is so key. And it just reminds me of my mom. She always takes like the stairs instead of the escalator or the elevator. And that's just the first thing that came to mind. But all the things that you listed are so great. And I'll even incorporate it in my daily life as well. So thank you so much. Big shout out to your first ECHO presentation. You did great. But yes, we will open it up for questions, comments from anyone. And I'm always happy to read out any chats that come in as well, so you can utilize that, but you're always welcome to unmute as well.
Well, I'll speak up first. Thank you very much, Dr. Martin, for your talk. You had lots of facts and really, useful information for everyone here. So thank you very much. It occurred to me, I was interested in one of your slides. I wanted to know, what do you think of Dr. Amjad's comment that healthy food is expensive? And the comment appeared to refer to that factor as a or the prime barrier to people adopting healthy food. Do you agree? Do you think that there are other social determinants of health that have an impact on access to healthy food in West Virginia?
I think I do believe that healthy food is a little bit more expensive, like especially when you go and buy vegetables. I remember going to one of the grocery stores and just buying vegetables, and it was in my cart, which was relatively, like, it didn't have a lot of things in it, but it was kind of, I ended up paying quite a lot and towards the end. And I feel like in some places there are more like food deserts, which means that there are more fast food places than the grocery stores where people can buy fresh foods. So I feel like that can, that plays a part sometimes.
If I can comment on that, I mean, when you live an hour or an hour and a half away from the grocery store,
Yeah.
you buy what you can stock up on because you're only going once a month.
Absolutely.
And the fresh foods are unfortunately not in that category.
That is true. And the other thing that I would like to add here is that the fresh foods, they only stay fresh for a certain period of time. So when you have just, you don't make a lot of money and you have some money and then you have other expenses on top of that. So what are you going to choose? You will choose food that will last for a longer period of time. So, you will go towards canned and mostly processed foods, which are not very healthy. Or might not be very healthy. Yeah.
May I ask, how do like frozen vegetables, are they significantly better than the canned ones? Where do they fit in this? Can we encourage that instead of the canned things?
So I spoke with a dietitian while I was working during my rotation in medical weight management clinic. And the dietitian, as well as Dr. Hegarty, who works there, told me that when you freeze the vegetables, it kind of stops that process, and it's a better option. to freeze and use the foods, because you're just kind of halting the process and saving the nutrients where they are at that time. So that is my understanding.
Thank you for the questions, Dr. Lelchik and Dr. Rexroad. Any other questions or comments? Janet, I see you chatted in there. If you wanted to unmute as well, you're welcome to. You're probably much more eloquent than I am pronouncing some of those prescriptions.
This question is maybe for Hugh to answer. I was able to get a prescription coverage for Wegovy for a patient this week. First time that's ever happened for me. She told me ahead of time that she had researched it and thought it might be covered, that she had an insurance plan, GEHA, which is a government plan for federal employee retirees, I guess. Anyway, I keep wanting to be hopeful that more insurance plans are going to cover such drugs as this. Any thoughts?
I do think on the commercial side, the coverage is getting a lot better. We tend to have a decent amount of success there. With the government plans, not so much yet, but we're working on that. And then I think the landscape's going to get a little more crowded here coming up. The tirzepatide product has been granted fast track status for obesity management, so there should be an approval coming for that soon. And then semaglutide, the makers of oral Rybelsus, their studies in weight loss have come out now that show that the oral semaglutide has equivalent weight loss to Wegovy. So I think this is a space that's going to get pretty crowded over the next few years. And hopefully the insurance plans, they usually lag behind a little bit, but hopefully they'll catch up with their coverage. I do think in terms of Wegovy and Saxenda, that coverage has been getting better, but it's been a slow process, especially in this area, which is unfortunate because you saw how high our rates of obesity were there. So that's not even just overweight patients with comorbidities. That's just obese patients at 45%, which is pretty alarming.
Thank you, Dr. Quinn. Janet, Robin, go ahead.
Now, so Hugh, what do you think about, and Maya too, all these medications like Ozempic is the big thing now people are taking for weight loss. I'm sure, I don't think there's any studies out yet, but what is the long-term effects for somebody taking that that's not using it as for diabetes, but using it for weight loss instead? And what do you think about people doing that? Like, do you think it's a safe thing? Is that what Wegovy is?
Yeah, so Wegovy is the same medication as Ozempic, just the two different indications. And then Rybelsus is the same medication also, but just oral. So they're all semaglutide, the same molecule, just different doses for different indications. Okay. The longest study we have, I think, is a bit over 100 weeks. I think it's about 109 weeks that was published. In general, we find that when the patients stop these medications, they do tend to put most of the weight back on, depending on how adherent they are to their lifestyle management. So when you are starting these medications, it is intended to be chronic treatment. It's not really designed to be short-term weight loss or anything like that. So patients do need to keep that in mind, that if they're just trying to lose weight for the summer, there's a good chance that as soon as they stop taking the medication, they do put a majority of it back on. But with lifestyle changes and dietary changes, if they do come off, they do have a chance of keeping some of that weight off, but they do need to expect to put some more on. So because it is chronic long-term treatment, I think patients really need to keep that in mind when they're starting this medication. It's not a silver bullet. It's not going to solve everything. They should try alternative methods, lifestyle management, things like that first.
Right. And I think as far as safety is concerned, when you go to a medical weight management clinic, they have a physician who's a board certified MD and a dietitian and a psychologist. So they're kind of covering all the aspects. So they will talk to you, they will look at your chart, they will do a detailed history, take a history and do a physical exam, look at your vitals before prescribing any medication. So if it, let's say, is not safe for you, they will not recommend you, because there were a lot of patients who would come to us and ask us about phentermine. But if you have a high blood pressure or high heart rate, tachycardia, you do not qualify for that. So they will look at you as a person, you look at your chart, look at your past medical history, your comorbidities before prescribing you any medication.
Thank you.
I've always hoped that medication therapy would help maybe tame appetite and help individuals learn how they can eat to maintain it, because it's a multiple of efforts that gives long-term success, not one thing, but multiple things.
Absolutely. And this is the reason why we start with lifestyle modification first. So, kind of tell yourself and teach your brain, to follow the lifestyle changes. And yeah.
Are there any cancers related to obesity that you know of?
So there was a slide in there that mentioned a ton of cancers there. If we can go down, yeah, this one. Yeah. This was taken
Okay.
from
Sorry.
National Cancer Institute. Talks about, the general category of what kind of cancer you can get in what organ.
Sorry, I did see that.
It's okay.
And Dr. Morton, I know you had a slide as well about how bariatric surgery is sort of like the last resort option as well. Is it true, it's kind of a two-part question, is it true that there is usually a psych eval associated with that before someone goes into that kind of surgery? And then two, if so, do you find that that's sort of a barrier for some folks who would like to proceed with bariatric surgery? I know sometimes whenever, a psych eval is involved, people might be like, oh no, are they gonna, I don't know, judge me, or am I not qualified? So kind of a two-part question.
So I haven't really worked in that department, so I cannot tell you for sure if there is a psych eval for that. And as far as your second question goes, you have to go through an evaluation and see if you are fit for surgery. So psych eval or not, I have worked in the surgery department in the past and have performed surgeries in the past. So when we have a patient who we have to do a mandatory surgery, like let's say appendicitis, we want to make sure that the patient qualifies for the surgery.
Thank you. That makes sense. Any other questions or comments from anyone? All right. Well, this has been so wonderful. I have so much gratitude for each and every one of you. Shout out to Dr. Rexroad for the case and Dr. Martin for the presentation. And also a big shout out, as always, from the folks from the residency groups. Robin, it's always a pleasure to work with you. And I always love emailing you about coordinating things. And Dr. Chris Martin, Dr. Lolchik, Dr. Gerbo, thank you so much for joining as well, along with all the residents who are on, and Dr. Hugh Quinn. Thank you for staying on here as the endocrine hub for ECHO. We really appreciate that as well. So if there are no further questions or comments, I'll just get into the announcements, and then we'll do a very quick poll for feedback and helps us improve as a program. So if you all could fill that out, that would be really appreciated. The only announcement is that the next session will be on June 28th, and Dr. Giordano will be discussing thyroid diseases and treatments. So keep an eye out for that reminder. And let me pull up the poll real quick. Okay, is everyone able to see that okay?
Yes.
Excellent. Thank you all so much. And anytime you finish this poll, you're welcome to just log off.
Great. Thanks again, Mithra.
Absolutely. Thank you all so much.
Have a good weekend.
You too. Bye.